with an aging population, it's only going to get more challenging for cardiologists. And this whole topic is one that has come to the front here at the CV Summit in Las Vegas. And I'm with Daniel Forman, who is an associate professor of Harvard. And Dr. Forman, you're head of the cardiac rehab lab at Brigham and Women's, right?
Yes,
at the same place. Can we talk a little bit about this whole concept? I mean, this is really nice that it's appearing at the CV Summit.
Yes, well, my other hat is that within the ACC, I'm the chair of the section in geriatric cardiology. We formed in 2012, and we were expected to be very small as a section of the college. The expected enrollment was about 250. Right. We're now over 2,000 members, including over 400 fellows. And so what I want to emphasize is what you've already alluded to, is that we're part of the conversation here at the ACC Summit. And I think it's a great forum for us to talk about the policy associated with caring for older adults, which is complicated, as we just heard in relation to one of the sessions that we were talking about with readmission. The issues in relation to age are more complex than many other patient groups. And what our group, I think, is bringing forward within the college is better tools and better thought processes in relation to advanced aging, and to really emphasize the demographics, that in America now there are about 40 million adults that are over 65, and the numbers are expected to soar over the next few decades. The number of the old is going to increase, and the issues in relation to this population is, one, more cardiovascular disease, more heart failure and coronary disease, and all these other issues that are the bread and butter of cardiology. But also with cardiovascular disease, there's a different substrate of patient. There's more comorbidity. There's more polypharmacy, where patients are on 20 medicines beyond their cardiac medications. There's more issues of frailty, and that impacts directly on cardiovascular management. There's issues of vision changes, hearing changes, and other types of sensory deficits that really compound the complexity. So in this meeting, when we're talking about readmissions and those types of complexities, I want to emphasize that it's not usually just an isolated cardiac issue. Usually any cardiac disease in an older patient is associated with other cardiac diseases. It's heart pain, chest, coronary disease is usually with heart failure and atrial fibrillation. That's already complex, but then you add in arthritis and COPD and cognitive changes, and it's more complex. Then you add in the medications, and it's more complex. So as we were just reviewing in the readmission session, the readmissions are usually not cardiac. They're for all types of other reasons, right, which is inherent with the age group. And again, to emphasize that these are not esoteric issues. This is mainstream cardiology. It impacts directly on the metrics by which we as cardiologists are measured. So it's the age issues and the non-cardiac issues which are intermixed with the cardiac issues that are so front and center.
I mean, time was when being a cardiologist meant taking care of the heart of the patient. Right. And now it really does, as the aging population shows us, it becomes a much broader picture. And if readmission is going to be not necessarily the heart, you really do have to look a little bit more globally at that patient sitting in front of you.
I agree totally. So it's a challenge to the cardiovascular caregiver community, because I think, with great respect for the tradition of excellence of the provision of cardiovascular care, I would say it's not enough in the current model. That I do think that geriatric precepts are part of being a good cardiovascular provider to an older adult. And so I think we have to grow. I think that, in terms of thrombosis, we became hematologists. We became smarter. I think we have to become smarter now in response to older adults. We have to think about issues of frailty, issues of the polypharmacies that are inherent with the age group, and other complexities of that sort.
One of the people who was in the audience, they raised a question. He said, not to be a clinical nihilist, but eventually these people are just going to die anyway. I mean, are we really going to move the ball down the court at all on some of these patients? You seem to be a little more optimistic about that whole question. Are you?
I'm very much more optimistic. Well, first of all, people are living longer. The average age of life now in America is 80. Which means that many people will live well beyond 80, so that even someone who's 90 has about 5 or 6 years of life expected in front of them. So quality of life, how do we maybe we will have less impact on length of life as people are reaching kind of a plateau of longevity, maybe. But certainly quality can be improved. And as we have a growing population that's older, I think we have to really think about that. It's not going to be something which happens out of a miracle. It's going to happen out of deliberate thought and planning. And so how do we pick provisions of care that really optimize function? We focus a lot on TAVR now. It's really brought forward some of these issues of frailty and issues, but I would argue TAVR is the tip of the iceberg. Aortic stenosis is just one disease. I would argue that every time somebody comes in needing a PCI, we should have just as rigorous a thought process as to what are the age complexities. Every time someone needs a device therapy for EP management, every time someone needs any other realm of cardiovascular management, we really can and should be a lot more rigorous in terms of improving a variety of endpoints, mortality, but also function and quality. And so as we talk now, another metrics by which we're going to be measured are patient-reported outcomes measures. And so I would argue to colleagues, to anyone, what does that mean when someone's 85 years old? We don't have as clear a thought as I think we might in terms of what's going to really seem optimal from the perspective of patients. And in this session, we're really thinking about what's going to be optimal in terms of the provision of care from an institutional level. So I think there's different dimensions of the problem. We have to really think about them all to provide excellent care.
In the Cardiovascular Summit that I've sat through so far, it's been a wonderful 2 days. One lesson that I keep hearing over and over again is no matter how well you do in a variety of different categories, no matter how great your institution is, there are probably certain areas you could improve on. Is that fair enough?
I think that's very fair. I think you've said it all. I don't really have a way of enriching that statement because I think it's really humbling. And I think that even the best institutions are excellent for different reasons from one to another. And I think that we really, in the case of the elderly, I think that we really haven't refined what excellence is really defined by so that we can really put it in a package and try to, generalize it to all institutions.
I mean, they were looking at somebody's numbers today, and it was, man, they're doing so well. They've got a straight A across the cardiology venue, and then they fail for patients who have pneumonia.
So,
I mean, what can you say except there are areas that can still be improved?
Certainly, the one thing which I think that implicit in what you just said is that the cardiac issues are tied to the non-cardiac, and I really do emphasize that as providers of excellent cardiac care, we have to think more broadly in the acute hospitalization, in the after hospitalization management, and in the chronic care management even for patients that aren't hospitalized.
And get your data.
Okay. Well, that's really true. Data is power, and data are power, and I think that we're really beginning to appreciate the breadth of data that are relevant.
Oh, Dr. Forman, thank you very much for your time. And for all of you, please, we have a lot of coverage in CSWN and CSWNI. And look around here on the internet because we have a bunch of interviews that we've done here in Las Vegas at the Cardiovascular Summit. For CardioSource World News, I'm Rick McGuire, Executive Editor.